Yeah.
Let's get started here.
Are you recording?
I am. So let's go back to the beginning. For first up, we'll do Fidge agent stuff, then I'll talk about clinicals. So where does superficial heat impact the pain cycle? There's for all of these modalities, there might be more than one answer. So, but the most obvious for superficial heat. Oh boy, this is I thought maybe we should have started this at 10 o'clock if this is where this is. Where in the pain cycle does superficial heat includes hot pack is the number one that we talked about. We also have Fluido and paraffin if that's available to you. So potentially some ischemia, potentially some, what did you say, Mary? Muscle guarding. Although I'm a little skeptical on that. Why am I skeptical on those? Penetration depth is something I'm hesitant to say it definitely will. But it's a good idea. If we need those things, the superficial heat's a good thing. And if the penetration depth seems appropriate to us, then perfect. That's what we want. What's the other? What's the number one thing it probably is doing? Activating the gate theory to block pain, blocking the T cell transmission. Good. Relaxation, yeah, and relaxation, both of like the patient just being able to get them to relax, but also that muscle guarding probably is part of that. How about our cryotherapy? Cold pack, number one most common. Ice massage. What's one benefit of each? What's the benefit of our cold packs? We don't have to sit there with it. Big benefit for me. Anything else? Just give me kind of why would a cold pack versus, if we're already down the cold route, we've already made the clinical decision, why would we use a cold pack versus other things? What'd you say, Mary? I'm having trouble hearing you today. All right, so you're talking about, I just want to know, like, why would you choose cold pack versus ice massage versus vasocoolant spray? That's the question for now. We'll talk about the cycle in a minute. Doing it concurrently with something else. Good. Any other benefits to cold packs? Bigger area. Yep. Yeah, I think that, and I think our cold packs, we can strap them and conform to a lot of different areas of the body. Benefits of ice massage. Gets the job done quick. Yeah. A little bit of massage at the same time. Yeah. Yep. Vasocoolant spray. It's so fun. You look really cool. Yeah. All right. So now let's ask the questions that everybody wanted to answer. Where in the pain cycle does this impact? Edema, probably number one. I'm a little hesitant though, because why? The penetration depth, again, I'm always skeptical, but yes, if they have a swelling of any kind, edema, then perfect. Let's put that there. Anywhere else that in the pain cycle? Another gate theory, right? Blocking the T cell transmission of that pain. Absolutely. Anything else? I think those are the big ones. How about our deeper heat? Well, I'll ask the first question that you guys want to answer anyway. Where in the pain cycle does deep heat impact? Oh my God, come on, guys. Like, I feel like you guys are just screwing with me every single day from the first day when you guys were switching seats and I couldn't remember anybody's name because you guys never sat in the same flipping spot. And now without answering questions that you just answered, you jumped the gun the last slide answering this question. Now I ask it, you guys are crickets. You guys, I cannot wait until we're done with this class and I don't have to put up with your antics anymore. Where in the pain cycle does deep heat impact? Muscle guarding, I think, is a great answer, Rob. Thank you for joining class. Anything else? I think T cells are a good one. Yeah, absolutely. Anything else? Probably ischemia as well, right? All right, diathermy, benefits of diathermy. Set it up and we're good. Yep, walk away. Yep. Big area. Yeah, bad things about it though. Takes up space, especially if we got to clear a radius around the patient because of those electromagnetic waves. Yeah, anything else? Yeah, you're probably not going to come across diathermy a whole lot in the real world. Treatment time, between 20 and 60 minutes, I have off the top of my head. So yeah, it is a long duration. Anything else? A lot of contraindications. Yeah, a lot of contraindications with that. Ultrasound, benefits of ultrasound. Why is that such a great choice? We can really focalize the area. Another thing for it, more non-painful stimulus, right? I mean, we can use that massage head the ultrasound head as a massage tool as well. And especially if you wanted to couple some of the other massage techniques you have with it, then I think that would work out really well. And yeah, focal area, more non-painful stimulus. I think those are two really good ones. Phonophoresis. Get to add medicine to it, right? So I mean, it's got everything that ultrasound has, except we're also delivering medication. You guys forgot what phonophoresis was? Where in the pain cycle does laser impact? But yeah, I think ischemia and metabolic waste are the big thing, right? So we're activating more mitochondria, creating more cellular activity. I would probably think that it makes more sense for the metabolic waste than anything else, but yeah, you're close right there. Anything else? So it has a better effect blocking the C fibers. That's great. Anywhere else? What's the downside though of laser? Yeah, minimal of that non-painful stimulus, right? You just put it on the patient and hold it there. There's less of that non-painful stimulus with laser. So that's a downside to it. Hydrotherapy, either doing exercise in a water or using whirlpool, sticking a piece of a limb in a whirlpool. Where does that impact? Definitely non-painful stimulus. I think with aquatic exercise, we have to consider the temperature of the water. Maybe especially as this group goes, that's something that we can consider. Yep. Anything else? So we can treat more wounds. Yep. Yep. That's a good idea. We could impact muscle guarding, especially obviously with whirlpool, we can set the temperature of that water. With a big, pool at the Y, we have limited option for that. But yes, absolutely, we can definitely do that. Yep. I will say one other thing that we haven't done much with anything else, because we're doing exercise. There's also something else that we're impacting. Potentially edema. You're right. Absolutely. And we could probably do that with whirlpool too. Have the patient move as they're in submersion water. Yep. I think with exercise, we're starting to get to the mechanisms of injury. If you guys remember that, I mean, we haven't talked about mechanism of injury enough, but yes, if they had big muscle strain because they lifted too much, exercise is going to help the mechanism of injury versus just the effects of the injury. So It's good. All right, eSIM for pain, Tensopia and IFC. What do they impact to the pain cycle? Easiest one is just, I mean, we're just blocking the pain. Gate theory, that's the number one thing it's doing. Yeah, I know for some settings on IFC, we could potentially be doing other things, but gate theory activated, blocking the T cell transmission is the number one thing. Pros and cons, TENS versus IFC. Portable is the big thing. Yeah, IFC, biggest pro, comfortable, right? And what's the other one? The large area, yeah. All right, Russian and biphasic. Where does that impact the pain cycle? So we could impact the muscle guarding is if they've got such a spasm and we've tried everything else, we get to tell them, hey, I know this is going to be terrible, but we're going to zap the heck out of this muscle, make it contract until it fatigues so much it gives up. So that's absolutely in the pain cycle the best thing. Absolutely. Yeah. So we're trying to re-strengthen something that's not working. Yes, absolutely. We're definitely impacting the more of the root cause than chasing pain. Good. Did you have something else, Mary? Were you raising? Oh, okay. High volts, galvanic. Where does that impact? Edema is probably the number one thing. I think with the wound settings, we're looking at more of the cellular structure, what's happening, which cells do we want to attract to the area based on the positive or negative or stage of wound. So there's some consideration for that. Anything else? Yeah, it's still a non-painful stimulus. It's not quite as comfortable as IFC, but yeah, it's still, yeah, that's absolutely part of it. Definitely. How about Ionto? Now we're delivering medication, which is going to impact the pain cycle, depending on what the medication is. Biofeedback. Muscle guarding is probably the number one thing that we're doing, especially if that muscle's in spasm and we can give that biofeedback to the patient, they can have that restore that brain body connection to relax that specific muscle. That's gonna really impact this. Absolutely. And then just like with the other stuff, man, with the muscle re-education stuff, we're attacking the root problem. So that's good. Traction. Potentially muscle guarding. You know, we have some settings that we could relieve some muscle spasm for that, Mary. You think the traction is an abnormal load? Okay, but hopefully not where when with this diagram, we said abnormal load is the thing that's creating the injury. Hopefully we're creating an abnormal load to take away the problem. So that's I think I understand what you're saying. Are you not understanding what maybe we're not understanding each other, Mary. We've had that problem for a while. All right, where else in the pain cycle is traction impacting?
So someone had to like this herniation, like with the radiating symptoms.
Yeah, I think so. There's two things. One, well, there's a few. Muscle guarding, everybody agrees. Yes, we get it. For some people, it's a non-painful stimulus. So that is going to help them there. I think what traction is trying to do is trying to attack the abnormal structure. The discus hernia is protruded. We are going to provide traction to give it the ability to recede back into its central space that it's supposed to be in. The the facet joints are impinged, we're going to give that a traction, a distraction to try to help free up that joint. So I think this is attacking the abnormal structure more than anything else. Massage as a whole, number one thing it's doing is what? Yeah, more non-painful stimulus. That's the number one thing all massages are doing. Probably not transverse friction, but let's keep going through. What are some other ways massage kind of clump together? A little bit increasing blood flow, good. Potentially edema, helping clear some metabolic waste potentially, yep. Muscle guarding, I think, is a good one, absolutely. Especially if we look at more of the trigger point massage, then that definitely is going to impact, but I think all of them can, yeah. And here's the long list of modalities that we learned this year. Isn't that something? Your whole semester on one slide. Is that it's a little defeating to me. Like, why didn't I just show this slide day one and then just take the exams? We could have done that. There absolutely is more to it. And when we start looking at this list, isn't it a little amazing, like how much you learned and know now versus beginning of the semester? And there's even more modalities that we've discussed a little bit and we haven't done. So the modalities will always be something that's in your back pocket to try. And there's always going to be a new modality. I don't care, you know, kinesio tape, cupping, dry needling. I mean, there's a long list. Some of them, the Practice Act says you can't do dry needling, but you should know about it. So then you know which patients, hey, I'm stuck here. I've tried this list of things. Let's go down that route next. So you're going to have to learn more and more about modalities to know how to best apply it to your patients. My least favorite thing about this class, though, is we spend all semester long talking about modalities, and I hope you never use a modality. It's there for you if you need it. If you're in a, at your clinicals, you're going to learn from your clinical instructor. What I hope you understand is that all of these modalities should be an adjunct to the rest of your treatment. It should be a piece of it and not, hey, the patient comes in, we line them up with 3 or 4 modalities, then they go home. That to me is not physical therapy. That is applying a bunch of modalities. And I think there's a time and a place for them. I do. We have private clinic places opening stretch labs, right? I mean, does every single person need to be stretched? No, but man, if it feels good and the market's out there, I don't think we should dismiss any of them, but we should apply it with our clinical judgment. Any questions about that? I know day one when I said I hated all modalities, and I've said it every single day since. So, but I hope you can understand where I'm coming from. All right. So the next thing I want to talk about are clinicals. I've been working on this a little bit. So let me see. All right, so our patient's journey is they start with their prior level of function. And then something happens, right? So that's the mechanism of injury, mechanism of illness. Something happens. So I was this, and then something happened. I think in the past I've used CC, chief complaint or current condition, as that, right? So I think mechanism, injury, or illness makes a little bit of sense too. That injury or illness causes a bunch of impairments. What do I mean by impairments? Functional deficits are gonna be over here. Exactly it. Poor range of motion, loss of strength, swelling, pain, weight bearing problem, balance problem, visual problem, cognitive problem, like whatever it might be. With all of your pathologies you've learned this year and are going to present in a little bit, you all know all of those. Some of them are predictable, some of them are scattered, some of them are really focal. Those impairments causes a change to their function, and that's now their current level of function. I've talked about this a few times, right? So the next thing we have are our questions and measurements is the next thing we need to figure out. For prior level of function, my two questions I try to ask of my patient or try to understand from my patient is, what are your responsibilities and duties, and what is your fun? Because we need to get back to, we need to understand both, right? I can't tell you how many engineers I've talked to, and I say, oh, you're an engineer, great. Do you guys know what engineers do? So yeah, it's one of those like, oh, you like play with Legos all day long, I'm assuming, right? So early in my career, I thought engineers were at a desk tinkering with stuff. I don't know what they're doing, but they're tinkering with stuff, right? Either they're using a computer to tinker with something, or they got a tool in front of them, they're tinkering with the tool, right? I've met engineers that are in front of a computer all day long. I've also met engineers. I met one guy who he was flown all over the United States to inspect underwater piping and welding. So that's his job as an engineer. So when on day one, I say, oh, so you're an engineer, great. I have two very different people there, right? So my questions are duty, fun. Duty can mean job. I think that's important for most of America, but it also means the family that I'm taking care of, my household responsibilities. Like there's a lot else to that. And then for fun, in this room, we've got a whole laundry list of what do we like to do for fun. And if we can, if this injury caused impairments to limit some of those things, I need to get back to those things. All right, I've got a couple of questions for my mechanism of injury. Is the injury or illness static or progressive? I think all of our diagnoses on our patho groups, they seem to be all progressive diseases. And, static injuries or illnesses just happen once and then they're not going to get worse, right? So a heart attack is a static problem, static injury, static illness. Although it's incredibly severe and there might be consequences that are going to be lifelong, but we're not constantly having a heart attack. And some people have repeat heart attacks, but I'm not going to wake up in the morning and say like, I'm having a heart attack day. That's not happening. I think all of these topics we talked about, they have bad days where whatever their pathology is impacts them more than some other days. So anyway, is it static or progressive? Another question I have. Is it temporary or lifelong? Ankle sprain, temporary, leg amputation, lifelong, right? Is it preventable or not? With all of your understanding of different pathologies we've talked about in patho, we've talked about a lot of those things, right? With each pathology, you should have some sort of understanding of those basic questions, right? When we get into our treatments, we'll see why that stuff is so important. All right, so our impairments, we've already listed some of them. And again, whatever the injury or illness is should give us predictable impairments. A heart attack, is it going to impact our range of motion? No, although if they're kept in bed in the supine position for 3 weeks while they're recovering, now is that impacting there, right? So there's secondary things that might be happening, but that's where our interventions are so important to prevent those other things anyway. So just the long list of things: range of motion, manual muscle testing or strength testing, swelling, endurance, balance, weight bearing abilities. We could go on and on and on. I mean, we've learned tests and measurements of all of those things, right? And we could even list more and more if we had to, right? Pain. What is so important about measuring all of those things? So we can track improvements and progression over time. Because is our treatment working or not? Our current level of function, we can also measure. First up is our fundamental function, activities of daily living. Can you perform bed mobility? Can you get out of bed? Do you have some sort of mode of locomotion? Can you toilet, bathe, groom, feed yourself, and dress yourself? If we can do those things, good, you can live at home. If you can't do any one of those things, right? Can this person live at home or not? We have to consider their family environment, their home structure. Like there's a lot more complication to that. The other thing is, we'll keep it here. Same words, duty and fun. Can that person work? Can they not? Do you have to be on light duty? Is there light duty? What do you do for fun? Can you still do that fun? Right. And I think all of us here, you guys haven't been having a lot of fun those last 2 weeks. How are your stress levels? Right. Do you guys miss seeing your friends, having fun, doing whatever their fun activity is? Right. Even for those of you that like to exercise, when you have to cut your run from 60 minutes to 30 minutes just because you had to do that other thing, you're just jamming it in, like it's not quite right, right? So, what are you able to do those things or not? And I'll tell you, we also have some ways we can measure these. A lot of our patient, if we can't measure it as a practitioner, goniometers, tape measures, speed of walking, all those type of things. There are questionnaires that can help measure some of these things. So anyway, we're always measuring everything that we possibly can. I've talked about 3 different physical therapy treatment goals. Big picture, and it can be applied into the daily picture as well. What are my 3 possible outcomes, 3 potential goals for physical therapy as a whole? The episode of care. Return to prior level of function. Now, will we always? So if it's a progressive disorder or a life, even if it's static but lifelong, then we might not ever return to prior level of function. We want to improve current level of function. And yeah, maybe if they were a mountain climber before, but they had bilateral leg amputation, they might get back to mountain climbing with prosthetics down the road. That's definitely my goal. But it's going to be different, right? I mean, and it's going to be a long road to get back to there. So there's a lot of other considerations for that. What's my third PT outcome? What did you say? Nah, I don't care about pain. You guys will care about pain. Your patients care about pain. I don't care about pain. Support. Yeah, I mean, that's, yeah. What is it? Prevent future consequences. And that's either because of their condition or because of a secondary thing, right? So, you know, the person who had a stroke and is going to be largely bedbound for the rest of their life, man, we've got a whole list of things we got to prevent. We got to prevent skin breakdown. We've got to prevent contractures. We've got to prevent respiratory infection just from being flat all that time. So yeah, we've got things to prevent. If somebody sprains their ankle, well, let's figure out, yes, ankle sprain. Should we reasonably expect to return to prior level of function? But shouldn't we also try to prevent future consequences? So, and I think the question is, was it preventable or not? If you're playing soccer and somebody slide tackles you in your blind spot, maybe it was an illegal play. Like, is that truly preventable? No, you're doing a sport, but if you're just walking down the sidewalk and you sprain your ankles like I do, all right, we've got to try to prevent that, because what's going to happen in 20 years if I continue to sprain my ankle? I'm going to fall, and then in 20 years, I'm at risk for fracturing things. If I'm going to fracture something, oh boy, now we've got a whole list of problems. So when you guys would ask questions, hey, would you ever do this? What about that? And the answer is always what? It depends. Do you see how many factors I have to figure out in order to get a good answer for that? Now, you guys on your clinicals, you guys are going to be asked, hey, you've got this patient. What are you going to do? This is your thought process. Your today's goal is one of these three things. That's today's goal. I'm going to work on these impairments in order to do one of these three things. Should we do, all right, let's, leg strengthening this person needs. Should we do, name a bunch of leg strengthening exercises. Quad sets, great. Squats. Hip abduction extension, good. So straight leg raise type stuff. What else? Hamstring curls, great. Deadlifts, great. Squat jumps, awesome. Lunges, great. Heel raises, great. Bridges, love it. So, what is it? Unbalanced surface. So you and Rob are talking more about balance. Stay within. So that's one thing we'll have to say. So they might need balance, but I asked for strengthening. So maybe that is. So we'll give you some wiggle room, but I said strengthening. You're talking more about balance. Clamshell exercise is great. Anything else? Any other? Pelvic tilt. Oh. Yes, fine, but I'm not doing them. Ooh. No, I'm good. Why would you choose one? I mean, we didn't even think that hard and we came up with a big laundry list. Why would you choose one over the other? Based on all of this stuff, right? If my patient wants to get back to mountain climbing and they have fair enough strength, I'm going to be doing hard stuff. We're going step ups. We're going to find the ladder. We're going to be doing tough stuff. if my patient has a progressive disease and it's going to really impact, and maybe there's contraindication to strenuous strengthening exercises, I'm looking to maximize their current level of function and prevent future consequences. I might just be working on bed mobility for that person, optimizing their movement, because I know down the line, that's the skill they really need. So we're going to start teaching them now. If they have cognitive problems, dementia, progressive dementia, it's going to be lifelong. I might start teaching them how to use a walker well before they ever need to use a walker, because their level of cognition is better today than it will be in 3 years when they need that walker, right? So the answer has always been, it depends. And what I hope that you guys can do within your treatments that you'll be asked to perform in just a couple weeks, there's going to be times you're overwhelmed. Simplify it. What do I want to do today? I'm going to work on these impairments, but I'm going to do it in order to do one of these three things. I'm going to know which one of these three things is the most important thing to target based on their injury or illness and my knowledge of that. If you can understand that, this job's simple. Do we have any questions on this part? Anything that's confusing? Do you guys feel like you can do that? Like it makes sense today, and you think, like, with all of the practice cases we've had, you think you can go back and say, I'm going to design a really good treatment for this person at this stage in relation to these three things? You feel like you could do that? Grab some of the practice cases and glance at that and look at it through that lens now. Can I do that? Okay, because I think you can. So first thing, what can you do? What can you provide for your clinicals and your clinical instructor? One, you guys are awesome people. From day one, usually it takes a few weeks to get some engagement from the group. Day one, you guys would not shut up so I could start class. You guys are, as a group, but also as individuals, some of the most energetic, charismatic, fun people to be around. So just by you showing up with your normal positive attitude, some of you have better attitudes than others. But just show up. You've already made my day better, because my day is better every single time I come to class. If you can make my day, so if I'm the instructor, if you make my day a little easier and a little bit more enjoyable, I'm going to give you more. So there's an exchange that happens between CIs and students. The more you take off my plate, the more I'm going to be able to give you. And so do the ultrasounds, do the SOAP notes, talk to if you have to earn the therapist's trust to do those things independently. But once you can start making their days a little easier, one, you're getting reps. Those are valuable reps for you because you're talking to a real person as you're doing that ultrasound. That's invaluable reps for you. But man, you make my day a little easier. I don't have to write that SOAP note during lunch. I'm going to talk to you about, hey, this afternoon, we got this thing. I'm going to show you this cool technique that I like to use for this, right? So that's the exchange that you get. You make the day a little easier, and I'm going to give you, the easier you make my day, the more I'm going to have just energy and time to give to you. So some of the things you should do, measurements, modalities, documentation, those things you should be able to do pretty quickly. It's going to take us all a little time to learn the documentation system of that clinic. And I don't know what your CIs are going to want you to do for that. They might say it's not even worth it to learn our system. You can practice writing your notes on paper. I don't know what their process is going to be, but those are three things off the top that you can do. Your decision making, that's the thing that you have the least amount of experience with. We've taught you, how do I measure this? How do I measure that? How do I measure that? How do I measure that, right? Can you perform this skill, that skill, this skill, right? So we've done that stuff. Now you're going to be able to apply it to the patient and hopefully have some good decision making with that. That is going to be the hardest thing for you to learn because we haven't had to yet. Tips and tricks. You guys have tips and tricks that your clinical instructors don't have. They have a million tips and tricks to teach you. So if you have a different way you know how to measure something, range of motion measurement, if you know a setting on a modality that they don't know of yet, tell them, do it in a professional way. You know, if somebody's doing shoulder range of motion differently than you've learned it, it's not wrong. It's just different than what we've learned it. And if you think you've got something a little bit better, say, hey, I want to show you what my instructor, what they told us in school, or I watched this video, here's something I got you. So those tips and tricks go a long way for both people. So just make sure you're professional when you do it. What do you want to learn? Man, you guys are going to get, this is the biggest step. The next those 6 weeks of your clinical is the biggest step to becoming a PTA. You guys just will become different people after your 6-week clinical. I know it doesn't sound like a long time, but it is amazing to see the growth. There might be a little pain with growth. Increasing our mileage is painful, right? But it is amazing to talk to students after their first clinical and to see them either in their classroom or just their overall presence. And it's amazing growth to watch from my perspective. And I hope you guys get it yourselves. Other thing, communication. You're talking with real people now. You're not talking with your classmates who don't have pain. They're trying to make up something. Like you are, that is a huge thing that you get to learn is just from your patients. Your hands-on skills, improvement in documentation, improvement in decision-making. Anything else you guys are excited to learn? Yep. Well, he only pointed to the people right around him. He didn't say these people. He was like, these people. Like he was very precise. I think the hands-on skills is something that we haven't learned a lot of yet, right? So I know if you took the exercise class, we learned how to stretch some people. We spent what, 3 hours learning that? You're going to get a lot more practice with that. Our hands-on techniques, we've learned some massage. Other than that, we haven't had a whole lot of techniques. I think you guys are going to learn a whole bunch more of that. So how to sync your clinical, how to do a terrible job, have a get it done mindset. When you cross off days on the calendar and say like, okay, good, I got 22 more days, like you are not taking advantage of the clinical in the right way. I know it's a sacrifice. It's a sacrifice financially. It's a sacrifice of time to do these clinicals. But if you're just looking to the end and not taking every single learning opportunity, you will not do well. Have a conflict with your CI. Your CIs are not getting paid. And well, they're getting paid to do their job, but they're not getting paid to be your CCI, your CI. So they're giving you their extra time, extra energy. They know that it's going to be harder, at least in the first couple of weeks, just because they're making sure that they trust you and that you can do the jobs, and then they're going to be trying to teach you. So learn how to resolve conflicts. And you know what? Who's the boss? The CI is. The CI is. So, understand what they're trying to tell you. And when they're giving you criticisms and asking you to do something better, you better listen because they are correct. We can all improve our communication. How many people think when I gave some feedback that you thought I was being a jerk? If Sarah was here, she'd agree. Right. So how do you say that nicely? Right. So there are going to be times when they might not phrase something as gently as you would like, but guess what? It doesn't matter. I don't care about your feelings. Learn from them because that is ultimately what they're trying to do. So the other thing, be a lone wolf. You have a lot of resources for you. Your CI is one of them. There's going to be other colleagues that are ready to help you. You have me, you have Tony, you have the rest of your classmates. You can always ask for help. Don't ever feel like you're alone. And especially in your first clinical, if your CI is trusting you with the patient and you think the patient needs to be progressed, or if you don't like a modality or it doesn't seem like it's working, or hey, the person said this, I was thinking about that. Feed that information to them. Don't go off on your own. Even if you know, hey, we did 3 sets of this exercise, the patient was not fatigued, they could have done 20 reps instead of 10. We need to increase the load. I was thinking this, is that okay with you? Right. So always, collaborate with that CI. You do not have the trust of anybody to do it by yourself. If you start doing things by yourself without checking with your CI, unless they said, stop asking me, it's time for you to do it. It would, if a CCI student on their first clinical, any first clinical student, I would not expect you to do anything without talking to me first. So make sure that you're collaborating. Complain. We can vent. You can drive home and say, I can't believe this is a problem, right? But again, that's a kind of a mindset thing, just like getting it done is. You can have a hard day. You can wish you did something better. You can wish your clinical instructor phrased something in a more gentle approach. But guess what? It's all just to have a good learning experience and to be the best that you can. Who's ever had like a sports coach or a teacher other than me, that's just like you hated then, but looking back, you can realize, well, I learned a lot and I actually, I got pushed in the right way, right? So some of you will have that person as a CI where you go, this person's a big jerk, but at the end of 6 weeks, you're going to be way better because of it. So it's okay to complain about the day, to vent, but don't let it stick with you. Also understand that it is a learning experience and you will be better for it. The last way to do a terrible job is to be a tech, be an aide. You're not an aide. You can help out if you don't have any patients and, everybody canceled. It's going to happen in the next few weeks. The first nice Friday, the first 75-degree Friday. If you're in an outpatient clinic, everybody's going to cancel. There's going to be tumbleweeds in that clinic. If there's towels to fold them. If you got nothing to do, vacuum the floor, whatever, like be a good team member. But if you're folding towels when there are patients for you to work on, you aren't making the most out of your time. So make sure you make the most out of your time. Even if your CI schedule has been canceled for the day, if there's another PT or PTA that has patients, see if you can work with them. So don't be a tech. Help out, be a team member, but don't fall into being a tech. So the best student I ever had, I was working with a patient and he was standing there and he was asking a bunch of questions and he had to go do something else. He left and the patient said, "Oh, is that your boss?" I said, "No, he's my student. What the heck are you talking about?" But his presentation, one, he was a very professional person. But in just how he was asking questions. So if you can think back to jobs that you've had, where you've had a boss over your shoulder asking you like, why are you doing it this way? What's next after that? How do you do that? Have anybody had a boss like that? That's what this guy was doing, but he didn't know the answer to the questions. The boss should know the answer to the question, right? It's a quiz at that point, but this person was just like, so why would you do it that way? How come your hand is here and not here? How come this thumb is here? Well, like he's asking all those intricate questions. So, if you've been a boss to anybody else, think of being a boss to your CIs. What are you doing that for? And is that because they have diabetes? You didn't want to do that. Did you consider their history of smoking with shoulder pain? Like, ask all of those questions. Do it in a professional way, but ask those important questions. Connect with your CI. I've talked with Sarah. She's got a guy, a former student of mine, that's pretty quiet. But find a way just to pull their personality. You guys aren't going to have a problem displaying your personality, but make sure you understand what your CI. Why do they get into PT? Why do they like working at this place? You had a million job offers. Why are you here? What's your favorite thing? Who's your favorite patient on this caseload? Who's the one that drives you nuts? Like, what do you like to do for fun? We're going to get out of here. you know, it's 6 o'clock. What are you gonna do tonight? You know, so connect with that CI. Preview before the day and review at the end of the day. Preview is you better know what patients there are, review their charts, kind of start predicting, hey, this person is coming in. At lunchtime, I gotta look up what this means. And then review at the end of the day, either with your CI or just on your own. What did I do well? What can I work on better? Because this person's coming back in 2 to 3 days. So what am I gonna do better the next time? Sometimes it's just during the drive, that's all the time it needs. Other times you're gonna need more and more, and you'll have to figure that out. Big thing, you represent your CI's reputation, and the patients are that CI's currency. Your CI gets paid because they see the patients and make sure they're happy and they keep coming back, hopefully resolving their injury, but you know, they keep coming back for visits 2, 3, and 4. The number of visits they see also impacts their pay. It could be for the week. There's different bonus structures where if you need a certain number of visits, right? There's also yearly bonus structures. There's also promotions that are involved. So as much as I complain about Joan, I love Joan. And if I'm going to have any student work with Joan, they've got to earn my trust, because guess what? It's my reputation on the line. And she's going to tell her doc, she's going to tell her daughter. My career is impacted by every single visit I ever see. Some of them I'm okay with letting them go, right? But you know, understand that it is you working with the patient under your CI, you are impacting their reputation. So you want to hold that as in high regard that it should be held in. Lastly is a good thank you is always important. This being your first clinical, if you make good impressions, I hear it all the time. Hey, my CI said they can't wait to hire me. I've got another year to go, but they've already got a spot they think for me. So giving that little thank you is important. So do we have any questions? Okay, yeah.
I had a lot of questions, but I'm nervous that is it, you know.
Yeah, and well, so he and I had a great relationship, and the patient, she was new enough where she didn't understand. I don't know why I didn't tell her about that, but yeah, so that's a good thing to have a conversation with your patient, your CI about. I've got a lot of questions. Do you want me to hold them now, or do you want me to ask them, you know, right now? So talk to your CI about what their preferred communication style is. And I will also tell you that some patients, I will say, no. I've seen Joan for 7 years. You can't say or do anything that will tarnish Joan's and my relationship now. If I've got a brand new patient that is also anxious and they don't trust me already, I'm probably going to say, hey, listen, sit there and smile. Don't do anything. After, we'll talk about this. So I think there can be a lot of variation to that, even between just me. So talk to your CI. Hey, I've got a lot of questions. Some of them you'll need to ask. Hey, I'm feeling this. What do you think about that? Some of them you'll have to ask right there. Other big picture stuff, you just talk to your CI about what they prefer. Yeah. Yep.
How often do we get interact with PT? Do we meet with them weekly?
So if your CI is a PTA and not the PT, is that what you mean?
Yeah.
Yeah, all the time. All the time. They'll be available to you via telecommunications anytime you're working with a patient. It could be a PT or a PTA. Do you guys in general know? We've got a good mix. So, yeah, nice.
I feel like an expected number, like, I think I'm just like, I had the thought of like, okay, here's 5 patients, like you deal with them. Like, is that like too many, or is that just a conversation?
That's a conversation, and you're not gonna be able to do that week 1. Your caseload We'll see what the exact requirements are, how it's measured in our documentation. I don't have that off the top of my head. In your clinical packets, it's somewhere in there. There's some things you are supposed to be able to do, all of the measurements that we talked about and modalities. There's certain things that you won't be able to, but by your last clinical, you'll be expected, your last week of your last clinical, you're expected to function as a new grad. Which is you have an independent caseload. It might not, I always consider it 80% of a season full-time is what I would expect. So if a full-time person is supposed to see 10 a day, I would expect a new grad to see 8 and be okay. So, but we can look at the exact definitions in our clinical packets. Yeah. All right. All right, well, that's it for me. I'm excited to see you on your clinicals. We've got our final exam on Thursday, right? And then last couple of practicals. So I know some of you, today is the last day that I'll be seeing you face to face. And I just want to thank you for just being who you are and making my job as fun as it is. So I appreciate you guys. I should have pressed stop recording before. Because now some people that don't deserve that message are going to go watch that. It's not for you.